what then do we know about the effectiveness of the standard vaccines for influenza in older people?
Oh, thank you very much for giving me that chance to show you the very latest results from the United Kingdom, just come out from England, actually. And what you see here is the adjusted influenza vaccine effectiveness against medically attended laboratory-confirmed influenza. Now, what you see is that for the live-attenuated influenza vaccine, the intranasal vaccine, which we give to our children aged 2 to 17, excellent results. You have got 57% vaccine effectiveness for the age 3 and 2, very good for the B, nearly 79, and if you take the adjusted vaccine effectiveness for A and B, is 65.8. But when it comes to the inactivated influenza vaccines we have in the UK, we actually see that in the active age of 18 to 64, it's down to 36.6. As a family doctor, I would like to see double that in that younger age groups, and it's not. This is what we get. But the data we have for the 65 says over, it's actually quite different. You see there, minus 68.4 for age 3 and 2, quite all right for B, and the adjusted for vaccine effectiveness for A and B is about 66.3. Now, having seen this, I must point out that the confidence interval is huge. There wasn't really enough numbers there to give us very good results, but the Public Health England has come out with these results. They were on BBC, they were on Daily Mail, they were everywhere. I think that we cannot say with confidence that the inactivated vaccine we have in the UK had last year actually worked in the over 65s. It hasn't done what we were expecting it to do. That's what I actually take from this slide here. And the Joint Committee on Vaccination and Immunization actually probably had already knowledge of these results, because in the draft minutes of June meeting, they point out that vaccine effectiveness in those 65 years and over showed a trend for lower vaccine effectiveness for age 3 and 2 in the elderly. And they actually qualify that you need to contrast it with a higher age 3 and 2 effectiveness in younger adults. In fact, the effectiveness in the elderly, the JCVI named as disappointing. That is the word they actually use. Not only that, but they decided that the review of vaccine effectiveness, which was scheduled for 2020, as regards to elderly, to the over 65s, will now be brought forward, because they say now we have other ways of boosting the immunity, the vaccine effectiveness in our elderly, and we're going to hear about that later on. Now, across the Atlantic in Canada, the SOS network looked at pool effectiveness over 3 seasons of the influenza vaccine in preventing hospitalizations. What they found was that the overall was 41.7%, and for the over 65s, it was 39.3%. In Spain, they found that vaccinated people had a 16% less all-cause mortality compared to those who were not vaccinated. And in fact, they gave us a figure that for every 430 elderly we vaccinate, 1 life is actually spared. And in the United States, the vaccination with influenza vaccine prevented 19% of influenza-related hospitalizations. What we learn from this is that the vaccines we have today are beneficial, are worthwhile. We should continue vaccinating. We must not stop vaccinating. It is very important to continue doing that. But at the same time, we need to find ways of actually having our vaccines more effective. Bologna looked at 11 years of data and pulled this data for seasonal vaccine effectiveness. And what you see here for B, in older adults and in working adults, quite a good vaccine effectiveness. Also for the H1N1. But when we actually look at age 3 and 2, what we see, vaccine effectiveness for the working adults, 20 to 60 years, is down to 35. And for the older adults over 60, it's down to 24%. We really need to do better for the age group that bears the bigger burden of influenza infection. As regards to persistence of protection within a single season, we have many studies in Australia, in the European Union, which at the moment includes the UK, I'm pleased to say. And what we see there is a waning of the antibody produced by the vaccine we give, which is inconsistent across the studies, the age groups, and the flu type. And this decline in vaccine effectiveness within the same season, it's actually more pronounced for the age 3 and 2. And in fact, this decline for vaccine effectiveness for the age 3 and 2, it can be even less than 0% by 4 months in several studies we looked at. There are other studies that show even greater vaccine decline in the elderly. This is a good study by Kissling. They looked over 5 seasons and they measured the vaccine effectiveness of each flu type in early and also late season. And what they showed that the vaccine declines progressively in that influenza season by about 8% per month. And what they also say in older adults, the vaccine effectiveness may not be there after 3 to 4 months for them. And here is the data on the right side is the early season, that is to say, looking at October, November, December, early January. And on the left, you see the overall seasons for all ages. And here is for the 60 years and over. And there is 3 months, and there is 4 months. And you can see already we're actually going towards 0 and below. So is this loss of vaccine-induced effectiveness in the immunity in our patient? Is it perhaps due to the virus changing and no longer being recognized by the vaccine antibodies we have actually given? Whatever it is, we need to really get flu vaccines that are more effective in producing a higher level of antibody that lasts for longer and can prevent hospital admissions and complications, and also vaccines that possibly could actually cover the age 3 and 2 degrees of drift that has a habit to do so. Can we do that? That's a question that we try to answer during this symposium.
Thank you very much. Come and rejoin the group, Dr. Kassianos, and we'll put a few of these points then to the wider panel here. Thank you very much for that coverage. That very, very interesting point you put there, and you mentioned the coverage that the data has had in the UK. People might be alarmed when they hear figures like that. Is it really not working? But is it even anything new, this phenomenon of the impact on the older people, the fact that there's waning? Is this a new phenomenon? Perhaps, Paul, I could put that one to you.
Look, I don't think this is a new phenomenon. I think there's a lot of worrying aspects of the data that George has put forward. I'd probably even take umbrage at the ageism of saying that, you know, on the western side of Europe, 50, 60, 70% is good coverage and bad at 3% on the east. Now, I agree 3% is bad, but we would not accept 50, 60% for our measles coverage rate or our pertussis coverage rate in children. We accept lower rates as being what we get in the elderly. And I think, you know, while it's important to look at enhanced vaccines, WHO and others, the International Federation of Ageing, are very keen to say 50 or 60% is not good coverage. We've certainly seen from George's data and others that the impact of this is even broader than just the hospitalisation and mortality. The vast majority of the hospitalisation and mortality is in the elderly. But, and I know Janet McElhaney's at the meeting, she's done a lot of work, as have others of the geriatricians, looking at the impact of influenza on frailty and the impact on activities of daily living. And right across the spectrum of frailty, if people get influenza, they do worse at the end of it. And while there are data about the increased mortality of 20% in the next 30 days and over the next 12 months, what worries me most is that these are people living productive lives and then they get influenza and then they're not. And even those that are already having some consequences, I can remember this year we've had a very big season in Australia, seeing one very pleasant little 85-year-old in a nursing home during an outbreak that was frail but was getting along with a pusher around the facility. The next day she was semi-lucid, lying by the side of the bed, incontinent. She had influenza, and that was close to what her new status was going to be afterwards. So this really has an impact not just on how you're hospitalised or you pass away. It has an impact on your quality of life from then on. You know, people who are hospitalised, a substantial proportion are then relegated to not being as independent and not having the same quality of life. So, you know, terrible data for hospitalisation, terrible data for mortality, very worrying data about the overall impact of our vaccines. And we saw the summary of the Bologna data there about, you know, how poorly we'd been doing. Data that came out about a year ago in Lancet Infectious Diseases. And so, you know, I think part of the message that George is pushing is that these are very severe impacts on the elderly, right across the spectrum of activities of daily living through to mortality. Our vaccines aren't working as well. It's been increasingly worse for H3N2 in particular as part of that. But part of the other message is we've got to stop saying, hey, we've got 50%, aren't we better than the Eastern Europe where they get 2 or 3%? We've got to be saying, why don't we get 90% of our elderly protected as part of the process?
Thank you. And George, you want to pick up on that? I mean, how worrying is this data that you've presented to us?
I'm a little bit worried about the data itself from the United Kingdom, from England, because they didn't have the numbers there to really come out with information like that. I would have liked them to have waited until they have really a lot more people in the study so that we can actually get better results. But the message to my colleagues is keep on vaccinating, and particularly audit and re-audit and target the high-risk patients. In my practice, patients with COPD, coronary heart disease, diabetes, and stroke, they have got a rate of about 98% vaccination rate. And as regards to children, I see so much less otitis media and children who come with infections that I need to admit them to hospital and so on. Why? Because we keep on vaccinating children, adults, everybody who needs to be vaccinated.
Thanks. And perhaps, Rodolfo, if I could bring you in on this then. We touched there on this waning effect. Is there a perception, do you think, that actually we've got vaccination programs and that they're working fine, and that there's a reality behind the perception?
Well, you know, we know that the flu vaccine is a very specific and unique vaccine that needs to be administered every year because of the drifted virus that is changing all the time. And because of that, then we have the seasonal annual vaccination. And there is no other vaccine that is like that. Other vaccines, they need to be taken only 3 times in your life or something like that in order to become immunized with the particular agent that we have. We have other agents that we don't have yet specific vaccines, which is also a problem. And we have been using the influenza vaccine for many, many years, and perhaps we have become complacent with what we were doing. But certainly, I think it's very clear that it needs improvement. So it's a vaccine that is working to some extent. It does some beneficial effects to the people that become vaccinated, but it needs to be taken every year. And it's a very complicated immunity due to this yearly vaccination that has to do also with boosting now antigenic scenes and everybody has a completely different history of immunization and exposures to different viruses. So complex vaccine, but certainly it needs improvement.
Thank you.